This is an educative video of microsurgical management of frontal basal epidermoid. This 15 years young boy presented with 3 episodes of seizures of 3 months duration with progressive weakness left side limbs. Examination showed Glasgow Coma score 15. He had expressive dysphagia with right hemiparesis 3/5. With this, he was investigated with CT scan brain and MRI scan brain, showed a large left basal frontal epidermoid extending from the base of the skull on the left side, parasagittal region going superiorly up to the caudate nucleus and paraventricular regions on the left side, and significant edema and mass effect on the basal frontal lobe on the left side, as shown in these various sections of MRI scans. He was taken up for surgery, underwent bicoronal scalp flap and left frontal basal craniotomy extending up to the midline and microsurgical total excision of the epidermoid. The dura mater is opened with the base towards the midline, and the midline is exposed and fox is exposed. This is a very important step to expose the fox and interhemispheric fissure. Once that is done, we need to follow the interhemispheric region and along the fox margin go down deeper. At the depth of about 2.5 centimeters along with the fox, the epidermoid is reached and exposed. The next important step is to open the arachnoid on the surface of the epidermoid and start the debulking or decompression. The opening of the arachnoid is extremely important step here to avoid injury to the surrounding important neurovascular structures like anterior cerebral arteries and their branches. Now I want you to see the epidermoid medial part along with the falx cerebri is exposed very well, and the capsule of the epidermoid is open now, and all this procedure or the process needs to be done under high illumination and high magnification of the microscope. The space acquired here is hardly about 1 to 1.5 centimeters by 1 to 1.5 centimeters. In that location, we need to excise the lesion completely because the tumor is on the left side and it's the dominant side. Now I want you to see the capsule is being exposed, and as we expose the capsule, now the capsule is opened and the internal debulking of the epidermoid is done. Usually in the literature and pathologically, epidermoid is pearly white and avascular and flaky substance and avascular in nature. The tumor gently is decompressed and debulked as shown here. The main aim here is to debulk the tumor and create a space for further microsurgical complete excision along with the capsule. Usually these tumors, they grow in the subarachnoidal plane and they keep growing into subarachnoid space in the crevices and in the arachnoidal spaces, and important neurovascular structures like circle of Willis and the branches of the circle of Willis and all the 12 pairs of cranial nerves which go into the base of the skull, they get involved in these epidermoids. So during the excision of these lesions, one must keep these important qualities or characters of the epidermoid in mind during the excision. They look simple and benign and avascular, but the encasing nature of these vital important neurovascular structures may create a devastating neurological deficits if we are little careless and if you are fast and not very fine in dissection. Now I want you to see the epidermoid in the central part, and the anterior and posterior part is very nicely dissected, and gently we are going from central to peripheral. Once you create a space in the center, the peripheral part of the epidermoid capsule is gently sector by sector and anterior, posterior, medial and superior, the capsule is pulled into the exposed cavity of the dissection and gently the tumor is taken out. We need to use a sharp, fine dissection when it is necessary to cut the capsule. Another important factor one must remember here is these epidermoids are very densely adherent to the brain substance wherever they are involved. Majority of the time with the fine dissection under high illumination and magnification and use of endoscope, we can dissect the capsule in majority of the cases. In few cases where the capsule is very densely adherent to the surrounding important neurovascular structures and the brain stem and the deep brain tissues, we need to leave behind the part of the capsule which is not coming out. Now, once we have done a fairly good amount of dissection, now we brought in a QEVO, an endoscopic examination tool of the microscope, and we inspect the cavity of the dissection which has been already carried out for the remnant epidermoid and the location of these remnants which otherwise are not visualized by the microscope. Now, with the QEVO endoscopic tool, we inspect the whole cavity inside and look for the remnant epidermoid location and how densely they are adherent to the surrounding capsule and their location. Gently, with this, again the microscope is brought in and the areas of epidermoids which were seen with the endoscope, now their microscope is applied there and those parts of the epidermoid are taken out completely. Now here the most important step in epidermoids is to take out maximum safe resection, because these are a benign lesions and they grow over decades and they keep recurring if a small bit of the tumor is left behind. And in this boy, he is quite a young boy and who has a full life in front of him. Our aim is to, as much as possible, avoid the resurgery in such children, to have a maximum safe resection and as much as possible to avoid resurgery in the future. With that in mind, we need to be very slow and meticulous and fine in our approach. Now you see, along with the small bits of tumors all around inside the deeper parts of the tumor capsule, we are going bit by bit, and small part of the tumors also is being taken away. Now I want you to see, we are now on the lateral aspect of the epidermoid. The lateral part of the epidermoid is still, there is a significantly large amount of tumor material still present there, which is adherent to the left side of the frontal lobe, basal frontal region. Now gently with the fine dissection, the tumor is separated inside and is brought into the operative field as shown here, and as it is brought into the operative field, we can extract it with a fine forceps and bring it out as shown here. Every movement here needs to be very slow and meticulous. At the same time, we have to keep in mind that we are not causing any bleeding inside the capsule or outside the capsule, because the capsule, as we go deeper and deeper, is beyond our vision, and if the bleeding starts beyond our vision, there will be significant brain injury. To achieve a hemostasis and coagulation, we may end up coagulating a normal brain. So every step here is very meticulous and slow, and keep dissecting, and every time when we do this, always look for hemostasis, always look for any bleeder there, and try to achieve hemostasis and try to have as much bloodless field as possible, so as to have a smooth, comfortable and comprehensive complete excision of the lesion. Now we are going posteriorly. The posterior and medial part of the tumor bulk is being dissected and brought into the field. Now I want you to see, now we have reached the most deepest part of the tumor and we are seeing the superior part of the corpus callosum, which is pushed downwards by the tumor in our MRI images and CT images. The part of the tumor which is dissected and brought into the operative field is gently extracted. Even when we are pulling out the tumor with the forceps, the movements need to be very slow and meticulous, not to have a jerky pulling, so that if there is any blood vessel or an important brain tissue adherent should not be injured. Now I want you to see the tumor is along with the capsule is separated and there is no practically bleeding at the tumor bed. The major bulk of the tumor from the anterior, lateral and posterior part is completely removed. That's a part of the capsule which is at the posterior limit of the tumor, and gently with the high illumination, high magnification, it is removed. Usually these tumors come bit by bit or piece by piece, and the movements need to be slow, as I mentioned to you earlier, and steady and gentle movements. This is the almost we have taken out completely now. Grossly, it appears we have taken out completely. You can see the anterior cerebral vessels on the surface of the corpus callosum from the both sides are visualized well. That is the superior surface of the corpus callosum. Again, at this juncture, we bring in the QEVO endoscopic examination tool and see how much excision we have done, so that the part of the tumor which is beyond our vision is seen and visualized. Now at this juncture, we use this endoscopic tool as an operative endoscope, and with the help of the QEVO or the endoscopic tool. If you don't have a QEVO, you can use a simple plain endoscope, 0 degree, 30 degrees or 45 degrees depending on the need at that juncture and at that location. So even routine endoscope is also of a great help in these cases. Now I want you to see, with the help of endoscope, we have almost cleared out everything, and there is raw area where the capsule was adherent. Now there's a part of the tumor still in the deeper parts on the medial side, just below the fox, is still there, and that part also is taken out. Taking out a small bit of the tumor again gives a tumor-free recurrence, long-term recurrence in these individuals. And since he's a young boy, he has a full life in front of him, so we'd like to give him as maximum tumor-free years as possible from our side. Now I want you to see the small bits of the tumor still there, adherent to the capsule on the medial side and posterior side. This will not be seen by the microscope, only endoscope can give us this picture. That part also is, now we know geographically where it is located, and very easily and smoothly with the microscope we can reach that part and dissect out the part. That is the posterior most part of the capsule of the epidermoid, which is adherent to the frontal lobe. Deeper aspects is gently being cut and removed. Probably that is the posterior limit. Now anteriorly again we have a small bit of a tumor which is adherent there. That also with the suction here acting as a dissector and under endoscopic vision, that part of the tumor also is taken out. As I mentioned to you earlier, even a small bit of tumor, if you excise, the patient will have decades of tumor-free survival or tumor-free period in his life. Now almost complete tumor has been excised, and we again visualize all 360 degrees inside the capsule and confirm the hemostasis. And every stage of surgery we need to wash the cavity with the normal saline, because these tumors usually they have keratin and cholesterol crystals in them, which may in post-operative time may lead to chemical meningitis, which needs to be avoided as much as possible. Now once the absolute hemostasis is achieved, we ask the anesthetist to increase the BP by 30 to 40 millivolts of mercury as compared to pre-induction level, and look for hemostasis completely for about 20 minutes. Now brain is lax and pulsating, absolute hemostasis is achieved and confirmed. Dura mater is closed, as much watertight as possible. Bone flap replaced and reconstruction done, and scalp closed in 2 layers. Same day evening we get a CT scan brain done. Tumor is excised completely. No edema, no hemorrhage, no mass effect. Ventricles are normal and no infarction. The histopathology confirms it is an epidermoid cyst, and this is his postoperative clinical status on day 2. Glasgow Coma score 15. He had minimal right side weakness, that also he has recovered completely. Now his power is 5/5. He is taking orally. On 5th day he is discharged home. That is his neurological status with no deficits. He is very happy to go back to the school again. This is our neuroanesthesia team, our treating physician, our neuro rehab team. Our presence online with more than 535 microsurgical, endoscopic, navigation guided, educative, neurosurgical, operative, procedural videos on our YouTube video atlas. Thank you very much for viewing.